Hello, I'm Professor Yang Seung Min. In this lecture, I'm going to talk about the mandibular anterior implants. Teeth in the mandibular anterior region are thin and narrow, and the bone below the teeth is very thin. So, inexperienced doctors have difficulties in placing implants there. How to place implants in the mandibular anterior region? How to make it successful? Today, this is the contents that I'm going to talk about. First, I'm going to talk about the characteristics of mandibular anterior region. Depending on the characteristics of the mandibular anterior region, we can make mistakes in drilling, so how to prevent the erroneous drilling. And I'm going to talk about the distal guided surgery for the region to prevent the drilling mistakes. Mandibular anterior region, as you can see here, the roots of the teeth are very small and the form is very thin compared to other teeth. Clinical photo, the teeth are extracted. The gingival thickness looks good, and I thought implants can be placed. But if you take CT of the patient, it looks like this. The contour, there's very severe labial concavity. The base at the bottom is wide, however, the concavity is very severe and it's very narrow. Unless you place implants very accurately, it is not possible to place the implants in the bone. So if you do not have a prior planning, you can go into trouble. Of course, with the planning, sometimes they don't go as we intended, and we need to consider that in placing implants. Characteristics of the region. After extraction, in general, there's high probability that the bone would be hard. A lot of cortical bone there, and the space is very narrow. And if you get the drilling point at the beginning accurately, it'll be okay. However, if you miss that, the drill can break through the labial or lingual contour, generating a lot of heat. That is the characteristics of the region. We looked at a patient's CT. After extraction, the contour is very narrow and it is not a favorable condition to place implants. I don't know whether you caught it in the picture. The inclination of teeth need to be checked. CT was taken with radiologically impermeable material. Looking at that, if you look at the inferior contour, that should be taken into account for surgery. As I said before, heating can be a problem and accurate drilling is not easy, and there is a high probability that the implant placement position would not be very accurate. Therefore, drilling in accurate position is very important. If you look at this patient, the same patient as before, the gingival contour looks okay, but labial concavity below is very severe. It looks wide from the top, but as I said before, overall, as you go down, it becomes very narrow. When implants are placed there, the positions are pretty good, and this is how they are placed. However, if you look at it closely, it looks okay in terms of the positions, like this. If you just look at the x-ray, you can say it looks very good. It's done well. In terms of the stability, we cannot determine it here by looking at this photo, but you can sense, based on my experience, it isn't good because CT can tell. We took great care. However, it is very much inclined toward lingually when we wanted to place the implants, but it was a situation the implant would be inclined labially. Number 41 was okay, but 31, the inclination was not good. How can we prevent that from happening? This can happen anytime. So we need to reduce the error rate of making this mistake. So drilling point is very important for that. We need to determine why that happens and how to prevent that. As I said before, the patient's reach width would determine the result. If the reach width is wide, we can drill into the position that we want, no problem. If the reach is narrow, during drilling, it can go to unwanted direction, lingually or buccally. How can we control the direction? In general, the drills that we have do not have the side cutting function. However, Ostem's 1-2 tapered kit has the side cutting function. Thus, it is good to use drills with the side cutting capability. As I emphasize this often, remaining true to the treatment plan is very important. So surgical stents would play a very important role for that, to accurately position the implants as we planned. The accuracy is increased with the guided surgery, so the guided surgery can be used partially. If we compare these three, we talked about the characteristics of mandibular anterior region. We need to be careful about heating, drilling at the exact point, and implant direction. In terms of them, they have merits and demerits. In terms of the accurate placement as treatment plan, on the most right column, the most important thing is we need to implement clinically what is in the treatment plan. So guided surgery is better. Surgical stent can be good depending on the skill level of a surgeon. If you just use the side cutting drills, even though you are very well skilled, the effect is limited, not much. This patient has a Maryland bridge in the mandibular anterior. A proper diameter implant is chosen. Deficient bone is addressed with bone graft in a standard way. According to the result, prosthesis is completed. If you look at the contour of gingiva, it looks very natural, and it is even above the contour of gingiva in the adjacent natural teeth. So if you look at here, you may think accurate placement can be made, but it is not as easy as you think. So considering that, we need to think about how we can place the implants better. For that, for more accuracy, digital guided surgery can be used. In general, before the digital guided surgery, a surgical stent can be used. As I said before, the surgical stent is similar to the guided surgery. It is a way of top-down treatment planning. The hole size can be decided based on the implant placement location, and the hole size can be enlarged or reduced depending on the preference of a surgeon. But this is not applied up to the last drill. In most cases, it is used to control the position of the implants, to control the distance between them. A clinician may apply the margin a little bit wider. This is not a mandibular anterior region. In the mandible, a surgical stent hole is made accurately, and you can see the position can be changed. If the hole is wide, the exact point in the surgical stent may not be at the accurate position that we want. If it is buccally positioned, that needs to be adjusted a little bit toward lingually. The holes in a surgical stent can be made very accurately, but it may not be so at all times, depending on the capability of a surgeon, so that errors need to be reduced. So the drill and the hole, the distance between them should be reduced, and the guided surgery system is the answer for accurate positioning. The best benefit of the guided surgery, which is different from the surgical stent, is that the drilling is not determined by the clinical experience of a surgeon. That is the best differentiator. Of course, it increases the benefit to patients as well. So what we do is performing the treatment plan. So treatment plan should be established first. In the top-down treatment, the crown positions are first planned, and the position, direction, and depth of implant according to the crown position is determined. After that, you need to consider whether soft tissue or hard tissue graft is necessary. When you use a guided surgery, you need to use a relevant software fitting the surgery. Using the software, the crown positions are determined and abutments are selected. Accordingly, the implant positions are determined. An advantage of using a guided surgery is that we can plan in advance all the desired positions of implants. If we can place implants in parallel, that would be ideal. If not, the positions can be determined considering the length of the dentular span or the gap with the opposing tooth. That way, even though the implants are not in parallel, we can create the form of prosthesis that we want. One more thing, as I said before, the guided surgery makes a big difference in terms of getting the accurate positioning and stabilizing the drilling path. If you look at the top of the guide, the sleeve part, the gap between the sleeve and the hole is very tight, stabilizing the drilling path. Let me explain what this means. Even though you're highly skilled, people can make mistakes. However, the mistakes can be minimized. For example, an excellent archer can hit the targets 10 out of 10, but an unexperienced archer has a low probability of hitting the target, a big difference between them. However, if you use a certain instrument, a beginner in archery can hit the target accurately. What is that sort of instrument? That's the guided template, which acts like a stent. A guide template can make you place implants very accurately in the position that you want, regardless of the clinical experience. Of course, you need to gain experience in the guided surgery, but implant positions and the depth can be controlled regardless of the surgeon's experience. And number of drilling can be reduced. So for patients, the surgery can be finished simply and saves time for surgeon as well. Ostom has MS implants and TS implants. The small one, 3.0 diameter implants, can be applied in the mandibular anterior, and the number of drilling can be 5 at most and 2 as minimum, greatly reducing time and gives benefit to patients. There are many areas where guided surgery can be applied. Among them, I believe you can use it often in the mandibular anterior region because of the characteristics of mandibular anterior, as I mentioned before. The narrow bone ridge, concavity, and inclination of teeth, all these need to be considered. If you are not skilled, you can easily make mistakes, and so you can benefit from it. If you look at this case in the mandibular anterior, this is similar to the previous case. So the teeth are extracted. Compared to the previous patient, the condition is better. However, positioning is very important here too. Before the surgery, we need preparation in the digital guided implant surgery. As I said before, we need to acquire patient data. Based on that, treatment should be planned. The treatment plan should be reflected in the template for the guided surgery. If you use it, you can do the surgery in a safe and fast way. There are steps to take, and if you are not used to those steps, it may take some time to get used to it. There are many different devices available. Today, many clinics have CT machines, so there's no problem with that. It's not easy to have all the machines or equipment beginning with the scanners and software and CAD machine. So this is a step-by-step process and it takes time, and you cannot do it all at once. At each step, you need to take time. For guided surgery, for immediate treatment, you need to prepare things in advance. In your clinic, if you do not have all the devices, it may take time, so you cannot do it all at once. However, it can give you very good outcome of treatment, and you need to compare different options and check clinical characteristics. Ostem has one guide. To use it, you go to the website and fill out the order form. Based on that, surgery report will be made. Based on the report, you can make some modifications. Looking at the condition here, you'll be able to understand how implant placement can be conducted. Based on that, one guided template will be made. Using the template, you do the surgery. The process is a little bit complicated. You need to interact with the design center. Once the template is confirmed, you use the template for the surgery. It is an online interaction, but still the process is required. If you think it is cumbersome, you may not like it. But if you take some time and get used to it, I believe this is a good way. So the surgery was performed on the patient in a flapless way, and the implants were placed in the desired positions. So if you look at the outcome, they are placed accurately as we planned. Of course, you can do the surgery with a stent or even without a stent. But as I said before, that can make changes in the outcome. So you need to select what you like, and if you use the technique of your preference in the mandibular anterior, I believe you will have good outcome. Summary. The characteristics of mandibular anterior, it has very narrow ridge and concavity. Accurate drilling is very important. Drilling can have a lot of errors, so you need to understand how to reduce the errors. One of the ways to reduce the error is the guided surgery. For guided surgery, you need to follow the workflow. You need to understand the workflow to determine whether the procedure is for you or not. If you determine that it is for you, you can apply it. If not, you need to get skilled in getting accurate positioning. The most important thing for mandibular or maxillary anterior is the accurate drilling. So various instruments, tools need to be utilized for long-term implant stability, and I hope you can utilize them. Mandibular anterior requires high focus during surgery. The bone below is thin and irregular, so you need to accurately understand the status of a patient before surgery and accurate diagnosis. If you use tools to mark the positions, you will have more successful implant outcome. Through this master course, you can understand the theory, and if you keep practicing, you can gain know-how, and I'll come back to you in the next lecture with a new topic. Thank you.